Qué seriedad. Qué disciplinados.
¿Eres mexicano?
Sí.
¿De dónde?
Cozumel.
Oh,
Sí, sí.
yeah.
Mi familia es toda chilena, por eso no hablo casi.
We're live.
Bienvenidos, bienvenidas, welcome everyone. My name is Alberto Díaz-Calleros. I'm the director of the Center for Latin American Studies here at Stanford, and we are resuming our Friday seminar in this quarter. Today's lecture, Exacerbated Inequalities, the Health of Indigenous and Afro-Mexican Peoples in the Context of the COVID-19 Pandemic in Southern Mexico, will be with Professor Lina Berrio Palomo. Kindly note that because the lecture is being live streamed, we will continue to have it available for the public in our class YouTube page once the lecture is over. For those of you who are watching remotely, please submit questions or comments into the YouTube chat, and I will make sure that I'm monitoring that and will read those to our guest speaker today in the Q&A section. For those of you, or those of us actually who are here at Stanford, I want to remind us that we are in the land and the territory of the Ohlone original peoples. We offer gratitude to the land, to the water, to the air that surrounds us, and I want to pay our respects to the past, to the present, and to the future of Ohlone peoples who continue to be present in their homelands and throughout the diasporas. I want to add one more thing I'm going to repeat every week in this quarter. Odilia Romero pointed out that a land acknowledgement like this doesn't mean much if we don't have admitted Ohlone Muwekma people into Stanford, and I hope we start thinking about that in those terms. Lina Rosa Berrio Palomo is a researcher and professor at CIESAS, at the Center for Advanced Studies in Social Anthropology, Pacifico Sur in Mexico. Her research topics cover issues such as sexual and reproductive health, indigenous and Afro-descendant peoples, and feminist anthropology. She has coordinated several research projects on maternal health in indigenous areas and works in collaboration with organizations of indigenous women and non-governmental organizations on the ground. Her current focus has been on the Afro-Mexican and reproductive health issues of traditional midwifery in Mexico. She belongs to SNI, to the Mexican Sistema Nacional de Investigadores, in the line of medical anthropology, and she's in the line of medical anthropology in the south, in CIESAS Pacifico. One of the things that she has coordinated is various projects having to do with how you link activists, feminists, and she has been at the core of these social organizations doing, I think the best word is really in Spanish, acompañamiento of women organizations for more than 15 years. She's also a member of CLACSO in the working group in Afro-descendants and counter-hegemonic proposals, and on the promotion committee for safe maternity in Mexico. Lina, it's a pleasure to have you here.
Thank you, Alberto. Thank you, Elizabeth, Sarah, and all of you for the invitation to be here with you in Stanford in these lecture classes. For me, it's a pleasure, and I'm nervous too, of course. But I know many of you don't speak Spanish, so I will be the first to present in English. It's not my language, and I'm not so confident, but I try to do that. So please. Okay. So, as Alberto said, I'm an anthropologist, so my research are based in anthropology perspective, are qualitative research, and I want to present the results of, or summarize 3 different research that I will be developed during 2020. And I prefer read in order to to be with the time. Mm-hmm. So 3 years ago, around March 2020, our lives were beginning to turn in an unexpected way. We were already beginning to feel the effects of a previously unknown virus that was already emerging as a major threat to the health and daily lives of millions of people around the world. Today, we may feel that this is an experience that has been partially overcome or from which we are recovering. However, as you can see, Almost 7 million people have lost their lives during this period due to the virus, and almost 700 million have been infected one or more times with the virus during these 3 years. We are well aware that although there is apparently return to normality, there has been much devastation, many losses, and setbacks in indicators, and especially lessons we are learning from this experience. The pandemic has also allowed us to observe with complete clarity the profound inequalities persisting in Latin America, one of the regions most affected by the virus and its effects. More of them are the other countries, and it's similar situation than in Mexico, because the inequalities pre-existent has increased the consequences of the pandemic. The pandemic has also highlighted the overlaps between forms of structural and institutional violence, gender and racial violence, which undermine the real possibilities of certain communities to cope with the onslaught of this health crisis. In one way or another, we have all been touched by the pandemic, and many families have experienced infections and losses, developed home self-care practices. I want to introduce a concept that is autoatención. It's a Menendez concept. It's different than self-care in English, because autoatención means the actions that people do to care the health or to prevent. It's not in the sense of be safe, do a sport, help. It's like when we were sick, we take a tea or whatever. It's the recognizing of this kind of medical attention that is not performed by professional or specialized attention. As you can see in the map, in the slide, what's the distribution of cases until 2022. For me, it's interesting now our continent and what's the distribution. Of course, USA is in the top, but it's interesting now the case of Brazil, Argentina, Mexico, Colombia, that are the hierarchies. In this presentation, I want to reflect on what the COVID-19 pandemic has implied for some social groups and how the structural vulnerabilities in health associated with the structural violence worsened with the pandemic. Critical medical anthropology allows us to approach for the political economy of health and the locally situated analysis which accounts for the differentiated experiences from the global south, in addition to generating an unequal distribution of both cases and access to vaccines between countries, but also, and this is my point, but also within them, and in the different populations. The analysis, as I say, is based in the next collective investigations in which I participated during 2020 and 2022. The first one is about COVID in 5 Afro-Mexican municipalities. It was performed with an amazing group of Afro-Mexican leaders, and exactly in the middle of the pandemic time in 2020. The second research is about midwifery. We are finished this research now about the diagnosis of midwifery, traditional indigenous midwifery in 6 states of Mexico. And this is part of my own research about reproductive health from Mexican and indigenous maternal health. I shared some images in the form of postcards. It's like 3 postcards just to show, with different insights to understand how the pandemic has affected these groups and generate forms of violence that are increasing. But at the same time, and this is very important, have activated strategies of attention and care where families, midwives, local communities have had a relevant role. And I want to start with the first framework about the structural and institutional violence and how it affects or produces vulnerabilities in health. In the case of Mexico, more than 7 million cases confirmed and more of 300 33,000 deaths is the official total of pandemic in Mexico until February 23. It's difficult to know exactly how many cases of COVID-19 we have actually had. We spoke about this with Alberto yesterday because they are underreported. We don't know exactly what the numbers are, what the real numbers are. Because the low percentage of tests performed is an important indicator to understand the magnitude of the situation. And one indicator is the percentage of excessive deaths. I don't know if this is a concept in English, muertes en exceso. The pandemic about excessive death.
Excess death, I think.
Excess death.
Yeah.
Excess death. For
Excess
example,
mortality.
Excess mortality, exactly. That are and a study for these colleagues from UCSF say the global rate is 17, but you can see the difference with Mexico. And in the other frame, you can see the official data from Mexico government, from health minister this year about what is the percentage of accumulative death in excess. So the high lethality is an expression of the multiple dimensions of the violence affecting the social groups. You can see that this is the same, this is the information of Health Minister, Mexico. You can see that the total number of excess of deaths and the percentage. You can see the worst part was 2020 and 2021. In 2022, it's different. So, since the beginning of the pandemic, there has been a rich academic production from various disciplines that has brought to the center debates on the violence exacerbated during confinement, the care crisis, and the persistent gender inequalities surrounding such work, the differentiated effects on certain racialized groups, such as Indigenous and Afro-descendant population, and the precarious situation of people linked to the sectors that have never suspended work. And in California, we have a lot of these Mexican migrant people. Never our food was supported by these farmer works that never stopped, that were sick, and in many of the cases, they can access to a medical attention. Not just here, it has been documented by colleagues in Brazil, in Mexico, and other. So I'm interested in think about the violence, considered not only direct violence, but also its structural, institutional, symbolic, and racist dimensions. For this reason, I begin by returning to the concept of structural violence, initially proposed by Galton and recovered from medical anthropology by various authors, including Paul Farmer, one of the most important anthropologists. Farmer's characterization has been central to the construction of a school of thought interested in thinking from medical anthropology about the interactions between what he calls the ethnographical visible, what we can perceive in daily interactions in the field world, and all the dimensions of history, biology, or political economy necessary for the anthropology of structural violence. For Farmer, structural violence is embodied through adverse events that anthropologists study and which manifest themselves through epidemic diseases, human rights violation, as genocide. Farmer works has inspired a whole stream of medical and other subdisciplinary anthropologists who have developed new concepts and incorporate additional dimensions. One of them, I really like it, the concept of Quesada, Hart, and Bourgeois, is about the structural vulnerability. A structural vulnerability is a positionality, a location in hierarchical order that includes the interface of their personal attributes, as you can see, as you can perceive by others, cultural values and institutional structures. those individuals are not seen in isolation, but as part of this articulation between individual and social aspects. So when people, and I want to remark this idea, when people are subject to structural violence, they become structurally vulnerable, and this has health consequences. Following this concept, I'm interested in thinking about how Indigenous and Afro-Mexican peoples, two social groups located at the base of the socio-racial hierarchy, have experienced the aggravation of their structural vulnerability in the context of the pandemic. An approach based on the dimension of violence and structural vulnerability allows us to understand how the territorial distribution of health services, and more specifically, those authorized to treat cases of COVID-19, correspond a criterion of concentration of population, an affiliation to Social Security insurance. This is really important to think what happened in Mexico and what happened in Latin America, because this is our centralizing the main urban centers, hindering access for those who live in rural areas. I want to start with the first postcard that is about Indigenous people and COVID-19. And this is just for focus on what is the Indigenous population in Mexico. That is almost 25% of population. In Mexico, as in other countries, the pandemic has predominantly affected populations that are in conditions of structural vulnerabilities. Regional inequalities and the precarious health infrastructure have generated important differences in the effects of COVID-19 between the regions of the country. In this sense, the global indicators, you can see, this is the last report of a health minister about specifically Indigenous people and COVID-19. The global indicators to measure the impact of the virus, such as active cases, mortality, lethality, and hospital occupancy, are important for comparative analysis between regions, countries, etc., but are insufficient to understand the effects on the virus in regions where the available data show underreported numbers, that is the case in Indigenous people, or data that doesn't exist, that is the case of Afro-Mexican people. So I want to put this challenge to think about what's the real impact of the pandemic in this population. The pandemic presents itself differently in a variety of ways in this country. We spoke about that yesterday. At the start of the 2020, it was evident that the highest percentage of cases were located in large urban centers and states with larger population, Mexico City, Estado de Mexico, Yucatan, Baja California, etc. At the beginning, many Indigenous communities closed with residents standing guard on the road leading to their communities, which resulted in lower cases number. On the contrary, some Indigenous populations, such as the Maya of Yucatan and Quintana Roo, linked to the tourist sector, and Mixtecos of Oaxaca, Puebla, Guerrero, etc., and other people connected to agricultural production, taught us different lessons. These communities were the exceptions. They had the highest number of infected cases from the beginning because they never stopped. During 2020, in many Indigenous communities, the pandemic was perceived as a distant event, and the cases identified were mostly associated with actors external to the communities, or with returning countrymen, with those who worked abroad and returned periodically. The feeling of remoteness and distrust regarding the existence of the virus provoked some people in Oaxaca, for example, erroneously attribute their death to other causes of religions, nature, or the age for older adults, saying it's not was the virus, she dead or he dead, but it's because it's a God decision, or it's because it's older, but not this kind of credulity about the existence of the virus. In the investigation carried out in the Costa Chica of Guerrero and Oaxaca, we documented that the majority of medical diagnoses were made through clinical approach, not by test. Because due to the absence of tests or the difficulties in accessing them due to the travel distance to the main urban centers, because those tests weren't available in their communities. Local clinics didn't have the tests available, and in many cases, local medical staff were left with no alternatives, even for their own health. I think last year I was in Costa Chica working in my field work, and one of my colleagues have COVID-19. She said, "Oh, okay, she feel bad," and she went to the city. And so I said, "Okay, I need to do a test to know what happened." But I walked for, I don't know, 3-4 communities looking for a test, but that aren't available or are available but the results is one day before or at so expensive, almost $50. So this is the conditions in this region. So in our research, we identified the perception of the pandemic by midwives, this kind of perception. It's important to thinking about the preventive measures taken by various indigenous communities and municipalities with the capacity to close communities and limit mobility, managed to keep their inhabitants to relatively low number of cases. But as May 2021, there were many indigenous communities and also Afro-Mexicans who experienced the presence of SARS-CoV-2 among their inhabitants in a massive way, disrupting daily life in a clearer way. To understand, so this is the idea, these preventive measures taken by the community, by the indigenous community that can do that, because not of all can do that, delay contagions but finally arrived in 2021 and 2022. To understand that underreporting, it's important to compare official data with local experience. In the Huave municipalities of the Isthmus of Tehuantepec, official data indicates quite low contagion and death data. However, the ethnographic information and the interview carried out with the health person show the seriousness of the situation. Most of these cases didn't have a diagnostic test, and therefore were never reported in the government's official database. For these people, access to a test means leaving the community, traveling to the nearest cities, paying for the test in the private sector, and therefore assuming the enormous cost of said test, especially costly considering the average income of population. In addition, those people who wanted to take a test were met with closed doors at the health centers and no access to treatment. I was doing my research in San Mateo del Mar, that is a Huave community, an Icots community in the Istmo de Tehuantepec, and by the social political conflictivity, and the pandemic, really the health center was closed by more than a year. So there are no possibilities to be attended in this municipality. So I want to put the focus about how important was the local attention, the auto attention, the domestic attention, and how it reproduced these inequalities. You know? So lethality is an indicator that allows us to understand the effects of structural violence on indigenous peoples in relation to the pandemic. You can see the difference, this is official data about the lethality. Lethality is the probability to death when you were infected. So the number of cases of contagion are really less in indigenous people, but the probability to death is higher. This shows the effects of structural violence materialized in the distribution of service networks with a higher concentration in urban areas. and the inability to respond to the health emergencies in the most remote areas. In conclusion, for this first postcard, apparently the indigenous population was less affected in number of cases than the rest of Mexican population, but the effects in the indigenous communities were more deadly. First, the lethality was higher. The exorbitant costs provoke a higher rate of poverty in those communities, and we can document it, for example, in the case of Afro-Mexican people, how many of families have to empeñar, I don't know what's the name.
Bon.
Yeah, and how important was the money sent in by USA in the pandemic time. Local preventive measures were fundamental to the prevention and the control of the infectious virus, but just in the first year. It was impossible to keep these measures after 6 or 7 months. So, a pandemic finally arrived. And domestic diagnosis and attention were fundamental. Okay, I want to introduce the second postcard and introduce you to another sector of population, the Afro-Mexican people, about whom there is even less official information and literature from government sources and social science research. We have a debt with Afro-Mexican people in order to understand what is the condition, what happened. Social science has to this debt. So, for the first time in the history of Mexico, the 2020 National Population Census inquired about the self-identification of people of Afro-descendant origin. More than 2.5 million interviews answered affirmatively to the question as regarding whether they consider themselves Afro-Mexican, Black, or Afro-descendant. And this is part of the campaign made by the organizations for people recognized. Guerrero, Oaxaca, and Veracruz, that is in brown, these brown states. Guerrero, Oaxaca, and Veracruz are the states with the highest percentage, and Baja California, with the highest percentage of Afro-Mexican. But the state of Mexico and the metropolitan area of Mexico City also stand out for their high numbers. Just because it's a lot of people, the percentage is really insignificant, but in the numbers, it was a surprise. More than 300,000 in Estado de Mexico, Afro-Mexican people, so it was a really surprise. So we can divide the Afro-descendant people in Mexico in 3 sections or 3 groups. The first and most literature speak about that is about the regions with higher concentrations of Afro-Mexican population, that is Costa Chica, the Guerrero and Oaxaca, or maybe Veracruz. But this is the distribution by municipalities, not by the state, it's the municipalities. And you can see how it's spread in different places. Obviously, we have a higher concentration in Costa Chica, but we have as the second group, that is Afro-Mexican and Afro-descendants residents who live throughout urban areas. And we don't have relevant data. We don't have data about this population. We can say this is an Afro-Mexican municipality, so I can show or I can analyze the data using the concept of this is an Afro-Mexican population. No. In Mexico City, on the urban areas, we can possibility until now to understand what happened. And the third group are Afro-descendants who are migrants from other countries passing through Mexico. And I'm sure this is the population that are in the worst conditions. They are invisible, totally invisible, and it's linked or experience the intersections of inequalities as Black people, as migrant people, as gender racialized, poor. So, with these political decisions about mobility of people. So, differently than other countries like Brazil or the USA, in Mexico, understanding the magnitude of the pandemic is even more difficult since we don't have differentiated data on COVID-19 because, as mentioned previously, this variable is not captured in administrative health records. Just until 2022, last year, and last year was the official document subido a la página de la Secretaría, was loaded in December 2022. That is the new formats to register when people come to a consultation by the first time. They ask, are you indigenous or do you consider indigenous? That's the only. Just until 2022, they include if you are Afro-Mexican, but just in 4 cases, not for all consultations. So we don't have data. That's a real problem. For that reason, and I say that the absence of information is a form of systematic racism, erasure, and violence. It's not just a statistical problem, it's a justice problem. For that reason, to analyze the impacts of COVID-19, we use a proxy methodology considering municipalities in the Costa Chica region, where 40% or more of the population has self-identified as Afro-Mexican in the most recent census from 2020. One of the problems, as most of these municipalities are not just Afro-Mexican, there are interethnic municipalities with the presence of Afro-Mexican, Indigenous, and Mestizo populations. So the diverse population of these communities creates another challenge to research, even if we can say this is an Afro-Mexican municipality. So we follow the data of COVID-19 in those municipalities. Even if they aren't ethnically differentiated, I use this classification as Afro-Mexican municipalities to conduct the analysis. We also collected qualitative information during interviews with local health persons, users, local authorities, leaders. In this sense, this is the Costa Chica of Guerrero and Oaxaca, and you can see in red the municipalities with higher percentage, more than 60%, and then how this is decreased. The percentage. You can see the concentration in this area, limit area between Guerrero and Oaxaca, that is, we know as La Llanada. And in this area, of course, municipalities have 90%, for example, of people that consider Afro-Mexican, but this decreased. So this is our region of work. Official data about the infections in this municipality was relatively low compared to national COVID average, and likewise with related deaths. However, this is the map we made in the first year. It's just for 2020. You can see this is the area, the Costa Chica from Mexico. As you can see, are not in red or brown. It's lower number of cases. But our argument is lower number of cases don't say nothing in this condition. Of course, it's lower because there are small municipalities, people are spread in the different, the contagions are not increasing faster. But we need to think about the other impacts in the daily life of this community. This health emergency and the challenges it has posed are articulated with pre-existing inequalities, contributing to greater vulnerability of this population to the virus, as well as any similar health emergencies. To cite just one example of this, it is this is the until June 2020, there are in these 15 municipalities, Afro-Mexican municipalities we follow, just 38 cases. And you can see how in 2020 this increased. So the pandemic, the life, but the right. And I want to introduce a discussion about other argument, that is the access to social security. Even if official data say Afro-Mexican people have almost the same rates of social, I'm coming. This is the percentage of insurance or social security. This is the national rate. In the case of Mexico, 70% of population apparently has or are affiliated to something. But it's important to say just 50% have IMSS, Instituto Mexicano de Seguridad Social, that is social security, real social security. 30%, 35% are affiliated to INSABI, that it's real open population, and this is the data about Guerrero and Oaxaca. And you can see the difference with these Afro-Mexican municipalities. So if you see the group, it seems like it's the same. But when you focus on these municipalities, taking just who have Mexico or IMSS or ISTE or what real social security is less than 2%. This population apparently have social security, but it's in INSABI. INSABI it doesn't mean nothing, the possibility to real access. So it's important to me present how this was perceived by the people, by the doctors, and this is the quote for the doctor, for the director of hospital, just to speak about how the consequences of the pandemic are the incapacity to attend the cases, and how the pandemic showed us the limits of health system in Mexico, especially in these rural regions. It's interesting, the interview with this hospital director, because he said, we were the first hospital in attend pregnant women with COVID, and we don't know how we can do that. We learned doing the practice, and we separate and we increase our capacity, because it's a little hospital, it's a regional hospital for the second level, but real is a very precarious. How was for this personal health the experience to attend in this condition and with less personnel, because more of them went out because they are sick or diseased or pregnant or whatever. So I want to stop a little and speak about how this kind of share of knowledge was important. She's a healer, a traditional healer, Lucy Mariche from El Chapo Redondo, and she's showing how to prepare the jarabe and medication to attend with the local plants. And this kind of sense were really important in different communities in this at this moment. And I want to stop just a moment to ask you, how many of you live within 20 minutes of a healthcare facility? How many of you will travel for 3 hours for a COVID test? Oh. How many of us, depend on a public health facility to access blood pressure or diabetes medication? This is not our case. We can do it. But for many people, the problem was not only the pandemic, but for many people, the problem was I can access to my blood pressure medication. I can access to check how is my diabetes or my pressure or whatever. All this attention was stopped during pandemic. So we need to focus not just in the number of pandemic of cases. We need to think about what happened. It's a very painful quote of older men. He say, I think they want dead us, kill us, because they don't attend. The pandemic has created sad older people because no one show us, no one attend us. So I'm not sick, but I'm so sad. And it's really painful, because it's the other perception. Many of families say, okay, mom, dad, stay alone, it's or for example, the difficult to assist to funeral rituals. That is so important in Costa Chica. Really, really important to build community, to network, to effective network. All of this was stopped. And it's like my cousin, my mother, my wherever dead, and I came like, so yeah, this is okay. And finally, I want to present the third postcard that is about COVID-19 and maternal health, just to finish my presentation with a more positive perspective and recognize the role played by these healers, by the midwives. This is a quote of a midwife in Los Altos, de Chiapas, and this testimony summarized part of the plot of this third postcard. On the one hand, the processes of sustained weakening and depreciation of traditional midwifery by the health sector, threats, mistreatment, lack of recognition, denial, or bureaucratic obstacles to access to the birth certificate of newborns when they are attended by midwives are some of the main documented difficulties and part of the daily institutional violence that they face. These processes have contributed significantly to the decrease in the number of births attended by them, as well as to the demand for care during birth by women. The second part of their testimony shows what we are able to document during the pandemic period: a significant increase in the care provided by them, not only during birth, but also in other health situations, including even mild or moderate cases of COVID-19. Thus, in those months, many of the midwives, so more women arrived at their homes to be cared for during pregnancy and during childbirth. This is the case of Josefina. She's Josefina. She's a young ICOTS woman and a midwife apprentice. And her youngest son was born in January 2021 in the midst of a pandemic with a traditional midwife who is a member of an organization of ICOTS midwives. During her pregnancy, she was treated by midwives and also went to the office of a private doctor in the municipality who asked her to perform the indicate ultrasounds for pregnant women as part of the biomedical follow-up. Usually the tests and specialized are not doing in the local rural. They have to go to main urban centers. Josefina had all the children with midwives, and she planned to do the same this time. So no, it's not a problem. She say she can do what she wants. But unlike Josefina, for other women, the pandemic meant a disruption in the forms of biomedical and hospital care, which for years has been considered for women as the safest and most viable, even those pregnancies that don't present complications or are low risk. The medicalization of the reproductive process, the effectiveness of biomedicine, and the actions aimed at restricting the actions of midwives have made biomedical medicine stand out as the hegemonic care option. Currently, traditional midwives attend fewer and fewer births in their communities. Officially, we have more than 15,000 midwives in Mexico, men and women. It's one of the highest number of midwives in Latin America. Until 1977, they attended almost 50% of childbirth in Mexico, 47%, especially in rural areas. Today, it's less than 2%. Why the decrease in two decades? One of them is global public policy to reduce maternal mortality. Maternal mortality is defined as death of women during the pregnancy or childbirth. And since the year 2000, when the Millennium Development Goals were approved, the WHO's commitment to reduce maternal mortality rates has been one of the main reasons for promoting childbirth care exclusively in the hospital health units. This has been an intensive campaign to eliminate home care for births, roll out at the first level of health care, which means health center, that could perfectly attend pregnancies considered low risk, channel pregnant women for the unit with the highest resolution capacity. Obstetric events is the leading cause of hospitalizations in Mexico, and that every year around 1,700,000 women are admitted for these causes. So it's really important attention. One of the direct consequences of this policy of international guidelines related to midwifery has been a awakening of the traditional midwifery, the direct prohibition of attending or the indication aimed at discouraging care with midwives. We documented that in our research. But this biomedical hegemonic attention showed their limits during the pandemic health emergency. Many of the hospitals that usually provide this obstetric care were converted into COVID-19 units, thus reducing their ability to monitor obstetric events. At the same time, the outbreaks of massive infections in hospitals, the saturation that several experienced at various times of pandemic, generate a perception among women of the danger of this space. They say, no, I won't go to the hospital because it's so dangerous, it's more dangerous than my home. So midwives' attention increased during this period. The midwives were an integral part of these care networks, attending not only pregnant women who came in search of support during pregnancy, at the time of delivery, or to care for the newborns. As you can see, the curve rise in 2020. You can see since 2050 how it's decreased, the number of delivery attended by midwifery. In 2020, it's increased. In 2021, almost maintained, but in 2022, decrease again. When the emergency pass or when the emergency ends, apparently, all return to the normality. So the deliveries were again attended in the hospital. Even if the pandemic less show us how important are midwives and how safe are the delivery at home with family, etc. But the return to normality implies to return to this hegemonic subordination and relation. I want to finish, share with you some quotes of how the midwives say they are looking for these women. Please, I don't go to the hospital. I want to stay here. In the case of Eulalia from Oaxaca, Angela from Guerrero. It was interesting because we did a research in the middle of the pandemic in 2021, and it was difficult. Sometimes it was difficult to locate these midwives. No, she's going to attend it. Oh, she's going to. And many testimonies speaking about how men's child, etc., were looking for attention for the COVID-19 and using the plants, herbs. Right. We have this is Nati. This is the baby. Nati is a June midwife. She's daughter of a traditional midwife, and she has the baby in the middle of pandemic. She said how important was this experience to let or to show us the place of women and the empowerment of the capacity to take a decision about in what place you were be attended. So, in conclusion, in this text, I have presented a reflection on the way in which, around the pandemic, pre-existing violence of the structural and institutional order is linked with the challenges that it implies. The disaggregation of the data is an essential tool to better understand the inequalities that have been revealed in this pandemic and its impacts on the various social groups. The lack of disaggregated data limits the possibilities of fully understanding the health, social, and economic impact of pandemic. This is particularly difficult in the case of Afro-descendant population in Mexico, since there was no data until 2022. Although the percentage of indigenous people infected with the virus was lower than the rest of the population, it has been documented that the mortality rate from COVID-19 was higher among indigenous people compared to the rest of the country. And this is not exclusive from Mexico. It's the same behavior, is the same situation in other countries with higher numbers of indigenous population. Thus, evidencing the effects of structural violence on their chances of death. In the out-of-pocket expense, I don't know if this is the name, gasto de bolsillo, that an economic catastrophe can mean due to the debt required to deal with it, and in the social consequences. I think we don't know exactly what's the consequence in the poverty or in the process of poverty for this community. So, pandemic has not finished. Apparently, pandemic finished because we don't have these rates of contagions. But many people in these regions left the school. I don't speak about the digital break or the digital gap. It was a really incredible how the mothers have to live with 5 or 6 childs in different age and try to explain how is the school, so this is other consequences. And some elements that make up this structural violence is the distribution of health service networks whose concentration is located in urban areas, as well as the units authorized to resolve cases of COVID-19. This geographic distribution implies enormous underreporting. At the same time, it plays the weight of care and prevention of the population, but without recognition the role of autoatención, of self-care, and the leading role of social group management. I also refer to the absence of social security among the Afro-Mexican population, and it occurs in a similar way with indigenous peoples, since the percentage of affiliation to a formal security system are very low. People then depend mainly on social health protection systems. We are also in the process of being dismantled, of being changed currently. The third situation of structural violence addressed is epistemicide and institutional violence against the practice of traditional indigenous midwifery, implemented for several decades. This is part of the imposition of highly medicalized model focused on biomedicine and institutional care of the reproductive process, relegating the women themselves, but also their partners, midwives, and family members. The field of maternal health is of fundamental importance to understand how the hospital reorganization aiming at managing the health emergency has been a lower possibility of access to health for millions of women who annually seek care. The close measures of partial restriction of the entry of people established by some indigenous and Afro-Mexican communities made possible to contain or reduce the presence of the virus and the number of positive cases during the first month of 2020. However, the pandemic arrived and had significant effects. And I want to find my speech speaking. We don't find scenarios of immobility or resignation by the people. In the absence of a state or in the incapacity to attend effectively, we have local governance strategies to manage measures to prevent or control the spread of the virus. Midwives once again became visible as a very important actor for obstetric care, not only during the pregnancy to which they have been restricted, but also in delivery care, as can be seen even in the official data in births. They are part of a collective network of care and support of life, which confront the structural and systemic violence. The pandemic leaves us with lessons not only referring to number of infections, deaths, or hospitalizations. It also constitutes an opportunity to observe and amplify the potential of these effective and affective networks. It's not just effective, it's a real affective networks. And the care communities and actors that make possible the social reproduction of life, even in the most challenging conditions as the pandemic time. So I want to say thank you. And this is you can see more of our results of our research. The first one is about the midwives. We produce a lot of documents and videos and interviews with midwives. And the second one, for if one of them are interested, especially in Afro-Mexican population, we publish the result of this research in this journal. So you can see. Thank you.
Lina, we have time for like one question from the audience, maybe, as we move into. Jose, go ahead.
Thank you so much for this presentation. It's incredible to have Mexico, and of course, a part of Mexico that's not usually featured in academic circles. And that's part of the question I want to ask. We learn very little about Afro-Mexican history back home, and perhaps the only case that we do is about the state of Veracruz. African ethnic populations being brought into the state and having rebel uprisings to create autonomous regions. I was not surprised to see a lot of Afro-Mexican communities were in the state of Veracruz, and I can expect similar stories for the Costa Brava, given the importance of the port of Acapulco. Mm-hmm. But I was very surprised to see Afro-Mexican communities in the state of Mexico. Mm-hmm. And I was wondering if there's a historical reason for that. And it's coming from a place of personal ignorance and trying to understand how did those Afro-Mexicans get there?
Migration, by economical reasons, basically. Yeah, it's a migration for this century or the last century, the second part of the 20. The last century, looking for job, basically. More of them are ubicated in the Nezahualcóyotl, it's not in the main. It's not Coyoacán, it's just in the periphery of Mexico state. And it's the similar pattern from migration here in California. People are looking for the family and networks and So it's really interesting. And the most important city with the Afro-Mexican people is Acapulco, in numbers. But by the percentage low, because Acapulco is a big city and many of people doesn't recognize us as Afro-Mexican, the discrimination, the racism, it has
Ivan,
quick. Sorry, I will bit. It's just a sort of question I had. I was wondering why, when you're talking about the self-identifying as different ethnicities, wondering why you had the fact the percentage of women, and I was wondering, I think it was 51% of women identified as indigenous, but 50% identified as. I was wondering why you had that, and if there was a reason.
It's a complex question. But quickly, because I know we have lots of. Many of these municipalities really are interethnic regions. Many of people say, I'm Afro-Mixteco, I'm Afro-Nahuatl, or my mother is Nahuatl, but my father is Negro. And this is it's interesting, and we need to look in more what the identity has been constructed. But this is the fastly answer.
Is there a tendency for what I was trying to get at, men not wanting to sort of claim a certain identity where women would be more happy to kind of do so, is what I was, is there like not embarrassment or like, I was wondering why women might be more inclined to say that they were Indigenous.
I think actually or currently the leadership in the Afro-Mexican movement are by women. Women are incredibly activists, protagonists in this process. So I don't know. I think maybe that you say it is who answer the census and who say who are part of this discussion about identity and about. There are a lot of questions about the how the census name. By your culture, you consider Afro-Mexican, so many people they say, no, by my culture I don't recognize as Afro-Mexican, but I'm Negro or Moreno or whatever. So we have to think more about that.
I have to stop this segment because this is the part that we broadcast openly. We'll continue the conversation here in the room, our smaller group. I do want to point out for those of you who are in the YouTube might not be able to read, it's a mural realizado por Ana Chopa y Niñas del Cuarto Campamento por Mano Vuelta, December 2021.
In the municipality of Santiago Tapextla in Oaxaca.
Because that slide might not be so visible in the YouTube. Please come and welcome us next week. Join us next week, April 14, with Professor Luis Cárcamo Huechante, talking about voices and sounds of indigenous liberation, statements of autonomy of Mapuche lands, which is part of the anti-colonial interventions in legal culture one-day hybrid symposium that is going on with ILAC, I think, is that event, right? Yeah. Thank you so much, Lina. Si quieres sentarte.
So we continue, yeah.
Continuamos, puedes pasar a español si quieres.